Okay, so my name is Nora Fripp. I am a research scientist at C2E2, or the Center for Clinical Epidemiology and Evaluation within VCHRI, and I'm going to be presenting alongside Smita Roy, who is a MSc student at the School of Population and Public Health. And our presentation today is going to be on evidence-based cost accounting for long-term care beds in home-based and institutional settings. And we're going to be presenting the results from a scoping review we conducted on this project. So we wanted to begin again with the land acknowledgement to acknowledge that the land on which we're gathered today, which is the land that many of us are fortunate enough to live and work on, is the traditional, ancestral, and unceded territories of the Coast Salish people, including that of the Musqueam, Squamish, and Tsleil-Waututh nations. So to jump into the background, I'm just going to start by defining long-term care as we're going to discuss it today. So long-term care, or LTC more broadly, refers to a range of services and supports that is provided to individuals who have difficulty managing activities of daily living due to chronic illness, disability, or aging. So within this broader definition of long-term care, we have institutional and home-based long-term care. The institutional long-term care is sort of that typical long-term care setting that we envision, and this involves care provided 24/7 in dedicated facilities such as nursing homes, and it includes medical care as well as personal support care. And then home-based long-term care refers to care that is provided within an individual's own residence, and it combines usually professional medical services as well as informal care from family members and potentially others as well. To provide a little bit of context about institutional long-term care in Canada, so long-term care is generally funded from both public and private sources, as is the case with other sectors of healthcare. Long-term care is administered provincially and territorially, and public subsidies do exist for long-term care, and these subsidies are usually income-based, so more available for low-income individuals. These subsidies can apply, of course, to publicly financed facilities, but also in some private facilities, depending on the province. And access to facilities is application-based and considers factors such as citizenship, residency, age, and health status, among others. So to zoom in and provide a few stats about institutional LTC in BC, and these are some stats according to a 2023 report published by the Office of the Seniors Advocates of BC. So according to this report, the average age for the 22-23 year of individuals in institutional long-term care in BC was 83 years old. The wait time to access long-term care on average across the province is 101 days. This does vary across regions, with the lowest wait time being in the Vancouver coastal region at 65 days, and the highest being in the Northern Health region at 278 days. And for folks in institutional long-term care, the average length of stay is 827 days, or 2.3 years. So switching over to the home-based care side of things. So it's widely understood in Canada and internationally that the volume of informal family care activity is immense, and that such care often reduces opportunities for education, employment, social connection, and well-being on the part of the caregiver. Of course, it can be difficult to quantify this care, but there's a report that was published by a group out of the University of Alberta looking at the economic value of caregiving that provides some estimates. So their work was based on a survey from Statistics Canada in 2018, and they found that there were 6.8 million caregivers in Canada who provide care to individuals with long-term health conditions, disabilities, or aging-related difficulties. And they found that these caregivers provided a total of 5.7 billion hours of unpaid care per year. And what they did is they used a replacement cost valuation method to generate an estimate for the value of this care on an annual basis. And at the low end of sort of their estimation range was a $97 billion value for the 5.7 billion hours of unpaid care on an annual basis. So, of course, it's quite staggering to be able to put a number to the family care and the volume of it, and sort of begin to understand how big of a role family caregiving does have in the larger care economy. And then just to touch on demographic trends in Canada that I think most are aware of, that are likely and already affecting the long-term care sector. So the life expectancy has grown and continues to grow in Canada. And this, along with the demographic wave of baby boomers entering later adulthood, is expected to lead to a scenario you can see in that figure on the right there, where in 2040, 2050, just under a quarter of the Canadian population is projected to be over the age of 65. So this projection will, of course, impose quite a substantial stress on the existing financial, organizational, and actual physical structures of the long-term care system. So there's sort of this need to examine the current state of the long-term care sector in Canada and potentially discuss alternative solutions to the traditional institutional long-term care. So with that, I'll pass it over to Smita for now to discuss the research gap we're hoping to address and talk through the scoping review that she led on this project.
So regarding the research gap, there is a significant gap in understanding how funds are allocated and spent within LTC facilities, which actually hampers our ability to assess efficiency and effectiveness in patient care delivery. So reports like Billions More Reason to Care, by the Seniors Advocate of BC, highlights concern regarding financial accountability in LTC facilities, emphasizing the need for improved monitoring and reporting mechanisms. And another study named Long-Term Care Financing for Fair and Sustainable underscores the importance of transparency in financing reforms to ensure equity and adequacy in care provision. So despite the substantial public and private expenditure in the LTC sector, there is a notable absence of a comprehensive cost accounting system. So this lack of transparency makes it challenging to determine the actual cost of care per patient on a daily, monthly, or yearly basis. For patients and their families, understanding how resources are allocated within facilities is paramount. Transparent cost accounting empowers patients by providing clarity on how funds are utilized to support their care, which actually fosters trust between the care providers and recipients. So to address this objective, to address this research gap, we have two objectives. Our first objective is to develop a comprehensive and transparent cost accounting framework for institutional and home-based LTC settings in BC. And our second objective is, using the framework structure, compare cost between institutional and home-based LTC settings. For this, we had two approaches. Our first approach is scoping review to identify key cost categories reported for long-term care to inform the development of a cost accounting framework. And our second approach is, using this framework, report a breakdown of home care cost from a caregiver perspective, which Jenny will present in the next session. So in our scoping review, we had two questions. Our first question was, how are costs accounted for in long-term care settings? And our second question was, how do cost and benefit compare between institutional and home-based LTC settings? So here is our PICO for the population. The population of characteristics is frail and elderly requiring full-time home care or LTC facilities. Intervention is patients receiving home-based LTC, comparator patients receiving care at an institutional LTC, and outcomes healthcare cost, direct and indirect, and accounting or costing categories. So this scoping review systematically searched Medline, Embase, CINAHL databases, identifying 3,700 records. After removing duplicates, screening titles, and abstracts, 198 articles underwent full text assessment. Ultimately, 37 studies met inclusion criteria and were synthesized for analysis. So, a little bit about the characteristics of our studies. The literature we have selected were published between 2014 to 2024. So, out of 37 papers, 14 focus on institutional LTC, while the rest are related to home-based care. The age of our population was more than 55 years, and they had diseases like cancer, dementia, heart failure, COPD, and Alzheimer's. And the location of our studies are Canada, US, UK, Australia, Sweden, Ireland, and other countries. So regarding the cost categories, we extracted costing categories from these selected studies to develop our cost accounting framework. However, there is a high degree of variability in how costs were reported and accounted across studies. So we pick here some of costing categories and the number of papers you can see in the right side. So in the costing categories, physician visits, we have found these categories in 15 papers, and prescription drug we have found in 14 papers. Personal care and home health in 10 papers, and informal care, we got it in 9 papers. Regarding results, costing results, so we attempted to estimate cost from the literature, but found a very large range of cost. So you can see in the table, like for physician services, the minimum value we got from our studies is like around $100, and the maximum is 6,000. And for nursing services, minimum is around 200 and maximum is 32,000. And for pharmaceuticals, it's minimum is 62 and maximum is 3,000. So we actually did not proceed with calculating and comparing cost from our selected studies. It's actually very hard to compare across settings and categories. And one thing I want to mention that we did not find any particular Canadian studies that aligned with our specific objectives. So from these categories, what we have found from our selected literature, we have developed a framework which Nora will present later on. So at this point, we actually picked 2 studies, highlighted 2 studies from our 37 articles. So this study actually about the informal care cost, the author is Higginson. So here the researcher explored the hidden cost and emotional impacts of informal caregiving during the last 3 months of life in England, Ireland, and US. They explored that family and friends provided extensive care, average around 100 hours per week. The activities included here like being on call, personal care, medical assistance, emotional support. And the cost of this unpaid care was actually striking. On average, 51,000 per patient, which actually consists of 58% of total care cost, and making it even larger than the formal care cost. So our next study is from Sweden. It's the study is about the societal cost of informal care, where elderly people are living at the community. So this study surveyed informal caregivers of frail elderly individuals who the age is more than 75 years and they are living at home. So the caregivers provided on average 245 hours of care over 3 months, mainly for household tasks like cooking, cleaning, shopping, transportation. So the average cost of informal care for this care estimated around 2,700 per person over 3 months, which actually annually near about 11,000. So the study underscores the significant economic and social contribution of informal caregivers. And right now, Nora will present our cost accounting framework, what we have developed from our cost categories.
Thank you. Yeah, so coming back to our objectives. So with the first objective being to establish a framework that we can use to account for the costs, and that can be used for both institutional as well as home-based long-term care settings. So as Smita said, since there wasn't an existing framework that sort of stood out and prevailed across the literature, what we've done is we've taken the data that we were able to extract from the scoping review and use that information, as well as through consultation with Jenny, who of course has firsthand experience with the costs associated with caring from someone from the home care setting. And we've used all that to develop this cost accounting framework. So the framework is structured into 5 main categories, with each one encompassing specific costing items. So the first category being medical care. So this includes items such as physician services, nursing services, and other allied health services. So things like physiotherapy, OT, and mental health counseling services. The second category is personal care. So this refers to costs associated with support for eating, support for washing and hygiene related activities, mobility assistant, and then any support and programming for outings or leisure activities. The third category is medical equipment and medication. So this refers to medications, and then other disposable medical equipment, and then the non-disposable medical devices such as beds, walkers, wheelchairs, etc. The fourth category is housing infrastructure. So this refers to any costs related to property maintenance and operation, any capital expenses. So for example, if a renovation was required either in a home-based or an institutional setting, any housekeeping and laundry related costs, food costs, and administration costs. And then the final category is societal costs. So these are costs that are not typically accounted for from the healthcare perspective, but capture broader economic impacts. So this includes items such as loss of productivity, loss of leisure time, unpaid caregiver time, and transportation. And then, so our second objective was to actually report the long-term care costs in BC according to this framework that we had developed, and then be able to compare between institutional and home-based settings. Unfortunately, at this stage, on the institutional side, and Jenny will present on the home-based side, but on the institutional side, we weren't able to fully complete this objective because there weren't any studies identified in the scoping review that were able to provide that breakdown that we were looking for. The closest thing we have right now is an estimate that comes from the Office of the Seniors Advocates of BC, and this estimate is an average per diem rate for long-term care facilities in BC in 22-23. This per diem rate is $255, which equates to about $7,700 a month. And this rate reflects the base funding that's provided per bed to contracted facilities. In the report, they state that this aggregate rate includes items such as staffing costs, food and supply cost, administration, repair and maintenance, housekeeping and landscaping services, property costs, and capital. So it does cover, there's a ton of overlap between what we've done with our framework and what is included in this. It is just an aggregate measure. So unfortunately, at the time, we're not able to sort of parse out what each of those exact cost components are. So to wrap up with some conclusions, so we found that the reporting of costs across long-term care settings was inconsistent in the literature, and there wasn't a clear cost accounting structure that emerged. We also found that literature from Canada and similar jurisdictions wasn't available to provide a detailed cost breakdown for either the institutional or for the home-based long-term care settings. And with this information, we proposed a standardized framework that we feel can help to address transparency and accountability gaps in long-term care cost reporting. And we feel that future research should be done to validate and refine the framework across long-term care settings, both institutional and home-based. Thank you very much, and we'll open it up for questions.
Thank you, Nora and Smita, fantastic. And I think what you have highlighted even on that conclusion slide really lends to an opportunity, both with this grant as well as for future research to start to work within what we're putting out there with this costing framework to look at a breakdown of costs of long-term care and home-based care, and be able to put novel additions into the literature and into a policy space where people can grapple with this more openly, I think. And certainly what we're going to hear in a few minutes from Jenny is leading the way on that for caring for one's loved ones on a home basis. Before we get to Jenny, though, just wanted to take a few minutes now to entertain any questions, comments, thoughts. So looking around the room, if there's anyone who wants to jump in. I know there's a couple comments online, which I will pose first to Smita and Nora. So the first one, just a clarification. Are these costs for informal care based on MD, RN, HCA? Home care assistance, perhaps combined. So are the costs for informal care, healthcare aid, thank you, Amanda. Are these costs for informal care based on MD, RN, and healthcare aid combined?
Was it for, which slide was that?
It was around the little review around the informal cost of care.
Like that I presented in the background.
No, the one that Smita was presenting. So if you go back. Here, that's costing.
This,
I think.
I'm not sure about like if this cost actually what they calculated. This is. So this is about they calculated the personal care, medical assistance, and emotional. It's totally in the house. I'm not actually sure they calculated this point or not. So, so they actually calculated only the personal care, medical assistance, and emotional.
Okay, thanks, Smita. There's a second question about whether there's any data comparing the amount of care administered by family and friends to those in long-term care.
There was actually a report, I think not from this exact group from the University of Alberta, but a different group that looked at long-term care that family members were actually providing in institutional settings, so not just in the home-based settings, but the fact that family caregivers actually are providing quite a substantial amount of care in institutional settings. So I think the number was about like 40 hours a month. So going in and helping with various activities within the institutional setting. And they did also point out that this had been affected, of course, by COVID and the restrictions that were put in place around visitation.
Great. Thanks, Ron. Further question online. What are the differences between in-home long-term care and home care services?
I think in-home long-term care refers to like broadly the fact that someone is receiving care that they would otherwise like receive in an institution, for example, and they're receiving that in their home. Home care services are services that might be a part of someone's home-based long-term care. So they might have clinicians coming from the health authority or whoever that's going to support their home-based long-term care, but there's also other stuff going on, like community caregiver and informal care that's forming the whole experience of home-based long-term care. Does that make sense?
It does, yeah.
Yeah.
That's great. Excellent. Any other questions in the room or online before we transition to the next presentation?
Just one on the slide before about the study in Sweden that had 245, is that including informal caregivers?
Yes,
Yes.
this is,
Oh, informal care. Okay,
yeah,
great.
it's informal care.
I just had a question. What was the rate they were using to come up with a dollar figure for the time that in these? Like
I
what
think
rate
it
per hour?
varies, like for this study specifically, or?
The numbers that have been reported here, I'm just curious how that was quantified into dollars from time.
I mean, I think that it would vary a lot across studies. I know that like that Canadian one I spoke of at the beginning of the presentation for like the valuing informal care. So they use like rates for like what it would cost to replace someone doing that task. So a rate for a personal care worker or a rate for a nurse. So it depends, and it would depend, I suspect, largely on where the study's being conducted, how they pay healthcare and care related
Okay.
professionals in those settings. But
Yeah.
do you know any more?
Yeah, like sometimes they actually also calculated the opportunity cost and loss of productivity for that particular work they will do, and they actually converted that value in the hourly amount, and that calculated.
Okay.
And in this study, did they say how much formal caregiving came from outside, or is it assumed that there's no formal caregiving, it's just informal?
So this study actually only focused about the informal care. They did not focus the formal care.
Because I mean, I'm just thinking out loud here. The care in the home, there's some help, maybe something from the health authority or from a private provider that comes into the home, purchased by the family. And then there's the family informal support. It's the accumulation of both that we're trying to say compare what comes into the home compared to what's happening in the care facility.
Yes,
I think that's kind of where we're going. Yeah.
definitely. One further question online to Nora and Smita. Are there any differences in funding between in-home long-term care and home care services? I don't know, Rizwan too, if you want to.
My understanding
If you
is-
have any thoughts on that, or
I think for home-based services, there is a user contribution. So the health authority subsidizes, so there is a subsidized home support that comes in, but there is a income testing that happens, and the client contributes, and then the health authority contributes the rest. So that is and those are the hours that go into the home. So there's that piece of it. And then, of course, if there's more that's purchased individually by that household, that would be private, and that would be their additional cost.
anything to add, Nora, Smita?
Yeah, I mean, I think it's similar to the question before of like the actual home care services versus there's definitely going to be other costs that aren't covered by like just the cost of the service, all the sort of costs that we discussed around personal care, other equipment related costs. These are all going to be costs that are likely involved in caring for someone in one's home that you might not see getting compensated.
That's great. I think we'll hear more about that from Jenny too.